I'm Dr. Carl Michel, practicing board-certified foot and ankle surgeon and proud member of T. Leroy Jefferson Medical Society here in Palm Beach County. Our organization takes pride in leading the way in subject matters that affects our community, one of them being the opioid epidemic. Our goal in this fourth series is to continue to draw awareness, educate our community, and help in the prevention of opioid dependency and death.
I'm Sandy Collier, and thank you all for joining us on this episode. We're going to talk about the latest medications and treatment recommendations when it comes to opioids. And I have the distinct pleasure of interviewing today a dynamic team. As a matter of fact, they're called the Dynamic Duo. And this is Dr. Angie Mason and Dr. Tyree Patterson. Ladies, thank you so much for being here.
Thank you for having us.
Let's talk about opioids. And Dr. Mason, I'm going to start with you.
Okay.
Physical therapists are able to curb the reliance of opioid painkillers. With this in mind, how do you treat your acute patients for pain?
So as a therapist, we spend an hour with them on the first visit. We're looking from head to toe what's going on, trying to find that root cause of where their pain is coming from. We try to curb the opioids or pain relievers because we want to find the root cause and not put a Band-Aid over it. If we can find out what's really going on, then we can dive in and solve that problem so they're not relying on pain medication, that they're not reliant on something external. So pain is a warning sign to our body. Opioids tend to take that away so they don't know how much damage they're doing to their body or if they're even making it worse by working through their pain. With us, we're looking at from head to toe. Let's figure out what's going on and how we can address it because it's a whole body. It's not just pain that we're looking for. We're looking to see what is the problem.
Dr. Patterson, as an expert in human movement, are there situations where you see opioids as more harmful than helpful to the patient and their healing process? And if so, yeah, right?
Absolutely. Like Dr. Angie was saying, opioids has what's called a Band-Aid effect. So our clients may not know what the true issue is or if it actually is pain, and it can cause them to do more damage than good, especially if we're doing specific movement patterns to help them regain either their range of motion or improve their strength. Like Dr. Angie said, pain is a warning sign, and it allows us to know, okay, something is going on and that requires our attention. But if the opioids is masking that, how would we know what to actually treat?
You guys talk about, treating the whole body and the whole person. Mm-hmm. So there's got to be some psychology to that too, right?
Absolutely. So pain is subjective. So my level of what pain is totally different from what you may observe. I have a high pain tolerance, meaning that I can take way more than even Dr. Tyree can. So for us, it's a psychological component where we're trying to mask, is it really pain that they're feeling, or is it the fear of pain? Is it the anticipation of pain? If the brain and the psychological aspect is not understanding what the true definition of pain is, the body will follow. So if I'm thinking I have pain, my body's going to find pain somewhere. And if I can't attack the psychology component of it, then I will never be able to attack the physical component. And that's why we love what we do, is because we get a whole body approach. We attack everything in that whole hour that we get to work with you. We're finding about your social life. Maybe there's economical issues that are causing you stresses that are turning into your body, relating it to pain. Let's figure out how we can help you with that. Our job is to be a community resource. We not only provide therapy, but we provide whatever you need. Let's figure out how to make you whole.
Yeah, and following that, also mental imagery helps with pain reduction and also that psychological component. Because if you can imagine what you're doing and you are taking the pain aspect out of it, your body will follow that performance to the way that you are imagining it.
Dr. Mason, tell me ways in which you can make an impact on the opioid crisis within trauma care.
So again, the psychological aspect, when we're with somebody, we're with them. One of the reasons that we stepped out and opened our own clinic was that we wanted to make sure that people knew that we actually cared. When you're with us, you're with us. My attention is on you. We're one-on-one, which means that I don't have to share my focus on anybody but you, so that you get that attention of from head to toe what's going on. I'm going to be empathetic with you. I'm going to feel your pain. I'm going to try to make you better before you walk out. So by being acute pain, that's immediate pain. That's let's get your pain down so we can get back to what we were doing in life, whether it's, if you're exercising, if you're just trying to walk, if you just want to stand up out of a chair without pain. Our job is to figure out how we can do that so that we are not having to go to medicine, because back pain is a chronic thing for everyone. We all have it, but how do you deal with it without medicine? That's our job to teach you that so that you know if I have pain again or I feel it coming out, I remember Dr. Angie, Dr. Tyree said I need to do these exercises, I should stretch these muscles. You're educated and you don't have to go and call the doctor and say, I need another prescription, refill. I don't have to go through that. I don't have to wait 8 hours for it to kick into my system. I know that these stretches help. I know that heat pad helps. I know ice helps. I know these other things that are superficial that I don't have to take medicine for.
You guys, you're explaining your role in the opioid epidemic, and you're explaining it well. Can you piggyback off of that, more of your role in the opioid epidemic?
Yeah, so like Dr. Angie said, our primary role is to educate on the adverse reactions to the opioids, educate on the proper benefits of the opioids, to educate on the proper usage of the opioids, to know when to take it, when not to take it, when to start weaning off, and that's when we come into play where we talk to their doctor who has prescribed that medicine. We can say, hey, Miss Susie, she's coming here for knee pain. Her pain is now subsiding. She's no longer having to need to take the opioids, but she is still having that level of discomfort. Can you give her something lower so then she can continue to tolerate therapy? So having that open line of communication with the physician can also help alleviate some of the opioid crisis and acute pain.
And that's basically right into my next question. Why should an acute patient choose physical therapy over opioids?
The great thing about Florida is it's a direct access state. So if you have pain, you can walk right into my clinic today and I can start working on you. Versus going into trying to schedule an appointment for a doctor, go through the redlining of, have you been on this before? Do you have other prescriptions? All that stuff. We don't need that. We don't prescribe medicine. We prescribe exercise. We prescribe movement because there's a kind of I'd say like an arc, a hill. We have to go over pain to get over it. So you're going to have pain and discomfort. We're going to do everything we can to help alleviate it. But when you get to the top, you're going to forget about the pain that you used to have because now you have movement that is helping your body. It's creating great endorphins that are great chemicals, hormones to our brain that's going to give you good energy. I mean, we are fun. Like, not tap myself on the shoulder, but every session is totally different. Every exercise is purposeful, and like Dr. Tyree says, education. A lot of times you're given stuff to do and you don't know why you're doing it. For us, you know exactly what you're doing it for, and that's going to be part of your exercise homework. So that's how we kind of jump in on that so that we can help alleviate that.
And that goes into how do you manage your patients around pain management, right? Because you know them individually, and you guys are fun. So a patient walks in with pain, what do you say to them?
So, like Dr. Angie said, we have a sense of empathy. We understand that you are in pain and no one wants to live with pain.
Right.
So, when a person comes through our doors and they have pain, the first thing is we will apply some form of modality, whether it's heat, whether it's ice, whether it's electrical stimulation, whether it's a form of dry needling, whatever the case may be that can help decrease that level of pain that they're experiencing in that body part, so they can in turn perform exercises that can help with decreasing their pain pattern. So when a person comes in, they're having acute pain, we alleviate or lessen that pain by adding modalities, and then we couple it with exercise specific movement to help decrease that pain continuously.
I like that. How do you work with other medical professionals to achieve multidisciplinary care to acute patients? Because you guys have to work together, right?
Absolutely.
How do you accomplish that?
We're on the phone, we're faxing, we're emailing. Our job is to get as much information as we can, but most importantly, that everybody knows what role they're playing so that the patient knows that we're all on the same page, which is their care. So if we have a referring doctor and we, as therapists, like I said, we do that comprehensive evaluation. There's sometimes things don't add up, and that is red flags for us. So we're on the phone like, hey, doctor, I know that this is what the diagnosis may be for their pain, but it might be something a little bit more involved, and they can go back and look. The doctors are with them, 10, 15 minutes. We get a whole hour. And not only do we get a whole hour, we get a whole hour of movement. So our eyes and hands are a little bit more involved, and we can be those eyes and hands to relate back that information to all the doctors that are in care. Sometimes there's a patient that may seem like they have a neurological component going on, and the doctor may not pick it up because the patient is sitting still and they can talk very well. But when we get them up moving, we see those cues of like something's not right, and we call the primary doctor like, hey, what do you think about sending this patient to a neurologist to get them checked out? So we are definitely a team player. We want as many hands and eyes on that person as possible to make sure that, one, if they are using opioids, that we all see, okay, are they overusing? Are they appropriate still? Can we start to wean them off? If they're not, if they're overusing them, hey, they came in here looking like this, there's something that we should probably do. Again, we're not pharmacists and we don't prescribe medicine, but we're definitely eyes and ears for them.
What are your methods of pain management for acute pain to prevent the progression or persistent pain? And you started talking a little bit about that.
Yes. So like I mentioned earlier, that level of modality. So just trying to figure out what is more specific to that patient and what would be more tolerable to that patient. So some people may be sensitive to cold, so we won't use cryotherapy is what they call it, but we'll use heat. Some people may just be nervous or maybe a contraindication of electrical stimulation. So if they have a pacemaker or what have you, then we're not allowed to use that kind of modality. So knowing that part helps us figure out what can we do to help prepare the patient in order to do therapy with us. Whether it's, again, mental imagery, whether it's breathing, whether it's pacing, some form of modality that's going to help them be able to do a movement that we need them to do later on in the session.
So patient comes in your door. How do you present an individualistic and realistic approach for pain management to that patient who's experiencing acute pain?
So I've been therapists for 12 years now, and you can tell, like, some people have unrealistic goals. You've had back pain for 20 years and you want me to fix it in 2 days. It's not going to happen. However, I can help alleviate some of it. I can help work our way to it. Your timeline and my timeline may be different, so we hash out, we negotiate what's realistic. Everyone in our clinic gets an individualized treatment. Everyone. Whether it's 3, 4 back patients, they're at the same time, they're all doing something different because they're different people and they have different goals. So for us, it's about what does this person need at this specific time. Sometimes there's regression. We get people to progress and they lift a box wrong or they moved quickly and they pulled something else, let's say for their back. It's a regression. It's okay, it happens. Let's get back to where we're going. So there's 2 steps forward, sometimes 1 step back. It's okay. We work through it to make sure that they're getting what they need. Everything is individualized.
Dr. Patterson, so I'm sure there are patients that come into you and they are on opioids. What role do you play in making sure that they're not misusing opioids?
Primary factor is education. We have to educate our clients on the proper usage of opioids, why are you taking the opioids? Are you really in that much pain that you need to take an opioid, or could you take an over-the-counter drug that's going to help decrease your pain? Because we have a pain scale, 0 being no pain, 10 being emergency room pain. And like Dr. Angie said earlier today, pain is subjective. So we ask that question to all of our patients who are experiencing pain. On that level, where do you fall in? Right. Again, we've been therapists for a long time, so we know when they trying to pull one over you. So they may say, oh, I have 10 out of 10 pain. I'll have my phone, so I need to call 911 because you're in that much pain. Right. Oh, no, I'm not in that much pain. Well, you walked in pretty good. Are you in that much pain? No, I'm not in that much pain. So just giving them that educational aspect of 0 is where it is, 10 is where this is. Where do you honestly fall in that category? And if for whatever reason you fall, let's say in that 7 to 8 category, then yes, it's okay to take that opioid. But if you are 5 and below, let's say a 3, 4, 5, then you don't need to take the opioid. If you don't want to feel that discomfort or even that pain, then you can go ahead and take an over-the-counter drug as long as it's okay with your primary physician.
Right. I agree with that. And as we're looking, sometimes I feel like we've been kind of programmed to say this is what I think they want us to say. And so with us being one-on-one, we're semi-direct. You serious? Like, I just saw you get out of the chair, you were walking, you bent down, and then now I'm asking you to bend and you're saying you have pain. So for us, it's, again, a team effort. So we're talking to the doctors, well, this is what they said, but their actions spoke differently. Or they came in and it looked like they were very unstable. We can't treat you that way. We can't work with you. You put us at risk, you put your body at risk, so we have to send you home and we'll let the doctor know that we canceled therapy today. So that's how we monitor the overuse for sure. If you come in looking like you have overuse, we definitely cannot work with you.
I would imagine that you guys get very up and personal with these patients, and which you should, right? How many of them have said, wow, I'm so glad that, you were real with me, and it helped them to reduce their dependency on opioids?
Pretty much all of them, if I'm going to be honest with you. Because people like the fact that you care and you go above and beyond to show them that you care. So having that one-on-one hour time where sometimes, it's a therapy session where we just sit and talk. Like, what is bothering you? Why are you feeling the way that you're feeling? What is your home environment? What do you have support at home? Do you have support from your family and friends? Because sometimes we have clients that come in and they are by themselves. They don't have family. They don't have friends. They don't have anyone to hold them accountable or even show them that they care. So then that's when we come into play and say, even though we are your therapist, we too are human. And we understand that you need A, B, and C or X, Y, and Z, and so we're here to help you with that. And then that's when we begin to build that rapport and build that trust, where they begin to let down their walls, and then they are more open and honest with whatever is happening, and then we can help guide them along.
Right. I agree. Our biggest thing about when we open our clinic is that it's a business, we get it, we got to pay our bills, but ultimately that we're family. Because if you trust me like if I care for you like your family, then you're going to do what's right by your family, typically. So when we go out and go above and beyond and they don't expect it, that gives them more trust and they pull down more walls and they're willing to be compliant. And then eventually they just come by and they just say hi and you see a different light in them. People come in with pain. Nobody's ever been able to help me. I've tried therapy before. It didn't work. And this is actually working. And I'm seeing results, and so now I don't need these pain medicines anymore. That's great. That's what we wanted. We didn't want you to become dependent on it. Our job is, let's alleviate this pain through movement.
Doctors, this has been an amazing session. I have enjoyed every single minute of this. Thank you for the work that you're doing in this community. Thank you for helping people. Thank you for helping our people. Thank you for helping everybody.
Right.
You guys are wonderful and you are dynamic.
Thank you.
I'm Sandy Collier, and we'll see you again next time. I'm Sandy Collier. We're in Wellington with Dr. Blaine Cameron. Dr. Blaine Cameron is an interventional pain management specialist. And Dr. Cameron, thank you so much for taking time out of your busy day to sit with us.
Thank you for having me.
Tell us a little bit about yourself, and then what is an interventional pain management specialist?
So after medical school, I did my residency in anesthesiology. And then beyond that, I did my fellowship in interventional pain management.
Why both?
Well, I enjoyed anesthesia. I really got pleasure from seeing instant pain relief from my patients, specifically, for example, in OBGYN, when you would have a patient who's in labor and you put an epidural in them and they're immediately feeling better. So while I was in residency, I was exposed to interventional pain management, the procedures. I really enjoyed the procedures and I enjoyed the benefits of them to the patient and seeing the patient's relief.
We have talked a lot about education and why it's important to educate the patient. Can you go into that a little bit more?
Well, as the physician, it's your responsibility to educate the patient. We found that patients who are better educated actually have better pain management. They understand their pain, they understand how to treat their pain, they understand their options, and this reduces anxiety. This has a multimodal effect on improving the patient's outcomes. As a physician, you really want to give the patient all their options. Opioids aren't the only option. Even within the medical space, there are several options beyond opioids. And outside of medication, patient has the option of physical therapy, they have the option of biofeedback, interventional pain management, several procedures that can relieve and alleviate their pain, and many other modalities. And you really want to educate the patient as to their options so that they can make an informed decision.
Let's go into some of those other options that you and I were talking about before we started recording.
Right. So as far as the options, as far as medications, there's several other modalities. For example, within the medication space there are the non-steroidal anti-inflammatory drugs, which a lot of people are familiar with. For example, Tylenol, acetaminophen, ibuprofen, Advil. These are all pain relievers that are not potentially addictive. We also have medications that are really good and designed to treat neuropathic pain, such as the antiepileptic drugs, such as gabapentin, Lyrica. We also have topical pain medications, such as lidocaine, capsaicin. We also have medications such as the serotonergic drugs, such as Cymbalta, duloxetine, which are really good for arthritic pain and neuropathic pains. And then the newer medications, such as the medications that have THC, such as dronabinol, which are really good for abdominal pain. So there's several other options other than opioids.
What are some new protocols that are put in place when prescribing a patient opioid for chronic or acute pain?
Okay, so very good question. As far as prescribing opioids, all providers are now required to look on and check their patient on both the national and in some instances state prescription data websites. For example, in Florida, we have the Prescription Drug Monitoring Program, which is more commonly referred to as E-Force. And what they have done is they have an algorithm where they have attempted to get a sense of how much at risk a patient is for the worst possible outcome, which is overdose. And so they've, for lack of a better term, given each patient a score, what we call an E4 score colloquially. And what that looks at is how likely your patient is to be unfortunately, involved in an overdose incident. It also gives the prescriber an indication as to which patients may be having difficulty with these controlled substances as far as addiction or even perhaps diversion. So it is now a requirement whenever you're writing a controlled substance that the provider must reference this database.
Can you explain some of the challenges as a pain management specialist that the opioid crisis has caused? And I would imagine there's probably a lot, right?
Absolutely, absolutely. So some of the challenges is this has caused an increased focus on the monitoring of the patient, which, as I aforementioned, involves referring to the prescription drug monitoring program, which now has increased the time to see the patient, is increased the time for the patient's interview and the patient's visit, as there's now more paperwork. The patients oftentimes they're required to sign an opioid contract. So this is more paperwork for the patient. This also is more work for the staff in the office. So it really has become a challenge as far as time, as far as paperwork for the patient, and as far as work to the staff in the office. And this, while it is designed to help care for the patient, it still adds a burden.
I've never heard an opioid contract. What is that?
So whenever a patient comes to see an interventional pain management physician, they're required to sign an opioid contract. The opioid contract is a document between the patient and the physician, and it essentially sets the guidelines. So the patient has an expectation and an understanding of their role and responsibility and what they can expect from the physician and from the office. So for example, some of the things that one would typically see in an opioid contract is the fact that the patient cannot see multiple providers, what is colloquially referred to as doctor shopping. They can only get their controlled substance from one physician. This is a safety issue. If one physician is monitoring it, then they can monitor and reduce the risk of opioid overdose. However, if we have several physicians who are unaware that the other is prescribing, these medications sometimes not only are additive, but are in fact sometimes synergistic, for example, the opioids and the benzodiazepines. So these are some of the things that will be explicitly delineated in the contract so that the patient understands what their role is and their responsibilities are, and what the consequences are if they do not behave appropriately and are not complying with the treatment.
What are some of the consequences?
So some of the consequences could involve discharge from the practice.
What are some of the latest medications and treatments being used for pain management?
So there's several medications for pain management. As a result of the opioid crisis, we now have a lot of medications which are, for lack of a better term, tamper-proof. For example, everyone's familiar with OxyContin. There's a new formulation now called Xtampza. And the benefit of it is that it is a lot more difficult, if not impossible, for people to inappropriately crush and inhale their medications and things of that nature, which alter the pharmacodynamics and therefore can lead to overdose and have led to overdose in the past. So we have a lot of new medications that are now tamper-proof. We also have a lot of new formulations. For example, there are new formulations with the buprenorphine and several other medications as far as the other classes of non-opioids that we also have available to us.
How do you treat a patient for pain that if that patient had previous issues with opioids? I must imagine that would be difficult, right?
Absolutely, very good question. So just because the patient has had issues in the past with opioids, you're still responsible to take care of their pain. So obviously one has to be cognizant of the patient's history, and obviously this patient is also not the best candidate for opioids. So in a patient such as this, you would definitely try to tailor your treatment more towards non-opioid treatments. For example, the interventional pain procedures. Because if we can take the pain away, we don't even have to address that issue. Secondly, if we do need medications, you'd want to maximize the non-opioid pain medications before we enter into the space of opioids. And even if you are challenged and you have to use opioids, there are different kinds of opioids. We have some opioid medications such as buprenorphine, which are what we call agonists, antagonists, and have a ceiling effect. So they are not as often abused as some of the other medications. And as I mentioned before, we also have some medications that are tamper-proof, so you definitely want the medications that the patient couldn't use in an inappropriate way that could endanger them.
So this next question would be, have fewer medications caused a decline in the opioid treatment?
Fortunately, we have seen a decline in the overdoses from prescribed medication. We still have a very large problem. Some of it is actually not from prescription medications. Unfortunately, there are a lot of illegal fentanyl, and I use that term loosely, prescriptions. We have fentanyl prescriptions such as, there are different variations. There's fentanyl, alfentanyl, sufentanil, and those are all legal. Unfortunately, people have figured out a way to manufacture other forms of fentanyl. So typically, if you go to a physician and they prescribe fentanyl, you just get fentanyl. Unfortunately, what's available sometimes on the street is something called carfentanil, which is somewhere in the order of 1,000 times more potent than fentanyl. And this is where we're seeing a lot of overdoses. And this is a formulation where even if you touch it, you can overdose. And we've even had the issue of first responders just coming in physical contact with their skin with the medication and overdosing. So now the first responders, the police, they all wear gloves as a precaution for this unfortunate fact that we're dealing with now. As far as there has been a limitation to the, I believe, in my opinion, the opioid treatment, because a lot of physicians have to be very cautious when prescribing opioids. We've also seen a reduction in the prescriptions from non-pain physicians because there's been a push to encourage pain patients to be sent to pain management. The concept is that if they come to pain management, they will be offered the interventional procedures, which they could not be otherwise, and thus can avoid this issue altogether.
How are patients who continue to need opioid pain management been affected by the opioid crisis, especially those with cancers and, that kind of ailment?
It has been very challenging. One of the issues is that the patients have a lot less access to their medication. They have a lot more difficulty getting their medication, and it's multi-pronged. It's not just the opioid crisis. As a result of it, we've also seen changes with insurance. So for example, when I trained, we would, in an attempt to reduce patients getting tolerance, we would do what's called an opioid rotation. I guess the analogy would be when you're exercising cross-training. By doing the opioid rotation, if the patient was getting tolerance to Percocet and you change to another medication, they wouldn't get tolerance, and then you can switch. Unfortunately, that is not as feasible anymore for several reasons. One being the insurance company would not cover, oftentimes, that new opioid medication. Secondly, one of the things they've done in the crisis is reduce the availability of the medication. So oftentimes the pharmacy just won't have it. And unfortunately, sometimes even if they're not changed, they have run into that issue where the medication is not available. So it has negatively impacted the patients who need it, unfortunately.
Dr. Cameron, as a pain management specialist, for primary care physicians who are listening, when should they refer their patients to you?
Excellent question. So we have had, just in the time that I've been practicing, many new procedures that have been fantastic for patients. So my advice to a primary care physician is whenever your patient has pain, and I'm in the past it was limited to epidural steroid injections, and typically primary care physician would refer the patient when they had radiculopathies or sciatica. But now we have a lot more available to us. So for example, even a patient with arthritis, something as generic as that, we now do radiofrequency ablations. So patients with knee pain, hip pain, shoulder pain, neck pain, back pain, that can all now be treated with radiofrequency ablation, which typically lasts a year and a half, sometimes as long as 5 years. And again, this can avoid your patient being on NSAIDs, being on any pain medications. So it's a fantastic treatment. We have several other new medications also for the more elderly patients who may not be surgical candidates. So I would recommend, and the current recommendation is that your patient be in pain management before surgery is offered. So patients who have spinal stenosis, we now have a procedure called minimally invasive lumbar decompression. Patient is not required to go under general anesthesia. Procedure is 30 minutes. The risk of the procedure is the same as for an epidural steroid injection, but the procedure lasts for years. So we also have procedures for patients who have headaches. We do occipital nerve blocks for patients who have occipital neuralgia. For patients who have tension headaches, they also benefit from cervical radiofrequency ablations. We also now have for patients with anxiety, we do the stellate ganglion block. There's been very good results from patients who have PTSD. And in fact, they did a study at the VA where they did functional PET scans and they saw a difference, and there was a significant improvement in both the reduction of the patient's panic attacks and the severity of the panic attacks. Because oftentimes the primary care physicians have to give the patients benzodiazepines, which are themselves addictive, and in fact oftentimes even more difficult to wean off than opioids. So I would say if you're a primary care physician, and I can speak for myself and I think I speak for all interventional pain management specialists, that we treat the patient and we're a specialist, but we send the patient right back to who they're comfortable with and who they're familiar with, which is their primary care physician. So there's really no risk to referring a patient to pain management. And I think that the risk of trying to treat it with opioids and with benzodiazepines are more dangerous than not referring the patient.
Dr. Cameron, thank you so much for taking time out of your busy day to sit and chat with us. I've learned a lot. Thanks for everything you're doing for your patients, for our community.
Thank you very much.
I'm Sandy Collier. We'll see you again next time. I'm really happy to be sitting here with Dr. Lauren Quinton. And Doctor, before we get started, tell me a little bit about yourself. You're a pharmacist.
Yes, ma'am. My name is Lauren Quinton, and I'm a pharmacist here in Palm Beach County. I'm currently working as an academic detailer under the CDC Foundation in collaboration with Florida Department of Health.
Dr. Quinton, what is your role as an academic detailer?
Yeah, so it's myself, and I have two other girls that work on the team with me to go directly out into the field. And essentially what we do is we try to make contact with as many providers as we can, and we create a toolkit based on the newest information that's put out, and it's upwards of 10 articles a day. So we'll take information from the community as a whole, then we'll take information from our overdose data to action program, combine it and put it into an easy factual format to present to these providers in the usual allotted time of about 15 minutes for face-to-face education or video education. And we essentially just give them the quick updates information on harm reduction tools such as PDMP usage, medications for opioid use disorders, and just any update that may be in their busy schedule they haven't been able to see or catch up on, and we just are there to inform them and say this is what you can do for your patients to limit the risk of opioid use or really any drug of substance abuse.
That's a really important role. What are some education initiatives that are currently taking place surrounding opioid overdose?
For us, especially in Palm Beach County, we're doing the Overdose Data to Action program. So we are taking statistics and all of this information, trying to compile it and put it in easily readable formats to the public. They'll be published. They can find them online just to read about, what's actually happening in our community, what drugs are being abused, what can we do to help if it's a loved one, or if we're a physician, it's our patients. So that's really, for me specifically, the programs we're using to try to prevent is just, what do we have, what can we get, and who can we tell?
Explain what the X waiver is. Why don't physicians need it anymore?
So the X waiver, it's done away with within the past month now, but it wasn't like a separate DEA registration that a physician would have to apply for in order to prescribe opioid medications for opioid use disorder, such as buprenorphine. So they would need this to be able to prescribe it, so it limited a lot of prescribers from actually giving patients medications to treat this. Only a small percent of physicians had them. I think nationally I had read it was like 26% of them had it, because it was an extra 8 hours of education to get it, and then it capped the number of patients they could actually treat with this waiver. So now SAMHSA said, don't even send us any more requests for it. You don't need it anymore. And so that's really benefited the public and medications for opioid use prescribing, because there's no limit now. So if you are a practitioner and you have a DEA registration, Schedule 3, or any, if you at least the Schedule 3, 4, and 5, you can now prescribe buprenorphine to your patients in any form. So you don't need that extra step to be able to prescribe them what they need. You also have now expanded this medication to the public, because used to a patient would have to actually search for a physician that could actually provide this medication. So there's a lot of benefits to getting rid of it, and it's also normalizing the prescribing of this medication so that physicians don't feel the pressure of, do I need to follow all of these guidelines in order to give this patient what they need.
And it's saving lives in the process, I imagine.
Absolutely. I mean, it's tools that we have right now. We're hoping it evolves, more and more over the years to come, but it's what we have now, so we need to be able to use what we have now to our best ability.
Talking about what we have now, what are some of the latest medications and treatments being used to prevent overdose in opioids? And you just talked about one of the medications. Talk about the rest of them.
Absolutely. So the one we have that's life-saving is the Narcan, and it's pretty easy. The training's easy. You peel it off, you put it in a patient nose, and you spray it, and it will immediately reverse those opioids, and it can restore breathing in a patient fairly quickly. So we have that. That is being distributed by Florida Department of Health. There's several areas where a patient can go get that free of charge. You can also get that medication at a pharmacy without a prescription. Medications that we use to treat opioid use disorder would be a buprenorphine, your Suboxone, which is a buprenorphine naloxone combination. There's a long-acting injectable for patients that have substance abuse disorder, and we use naltrexone here and there as well. And then methadone, but methadone has to be given in a SAMHSA certified hospital, and it's usually a treatment plan of at least 12 months or longer. So it's kind of the mainstay right now are these few medications we have to treat it, but if used correctly in treating the whole patient, mental health, their socioeconomic factors, and these medications all together as a full treatment plan. It's been the best way. It's pretty effective currently. But also, you know, opioid use disorder, substance use disorder in general, is very hard to treat. So it's a community effort of practitioners and, you know, outreach, as well as caring about that person as a whole and what really is the driving factor that led them to this and to this situation, and you know, understanding every single aspect of what led to this problem and seeing that human is really going to be the key to treat this nationwide in the future.
Dr. Quinton, we used to hear a lot about methadone, but now buprenorphine is kind of taking over, right? Why is that?
Yeah, so it's just more accessible. Methadone, you have to get it from a SAMHSA certified facility. You have to go in and get it. Prescribers can't just prescribe methadone for the treatment of opioid use disorder. So buprenorphine or, you know, Suboxone, these versions of this drug have came out, and they can be taken by a tablet every day. There's a long-acting injectable, and there's a sublingual film that they can use, and you can get these from any pharmacy or even in a mental health clinics. If patients are admitted, they can get those easily there as well. But they can be prescribed. They can pick them up. They can take them home. They can take them as prescribed, just like they take any other medication under the supervision of a physician. And so it kind of takes away that treatment plan of having to be at a clinic to receive your medication, and it provides that, like I said, that craving, less of a craving needed by still giving them a little bit of what they need and gradually tapering off the patient, you know, lower and lower to eventually get them to where they would hopefully not need the use of opioids anymore.
Doctor, there are a lot of preventative programs out there right now. How are you able to inform all of them about the latest opioid statistics?
Yep, so we'll educate them on, you know, the latest medications to treat opioid use disorder and all the latest up-to-date articles that we have read. We'll also get out in the community and we will educate them directly. A good tool that we have is just information on Narcan. If you have a loved one, you yourself, anybody in the grocery store even, like if you have Narcan, here's how to use it, you might save a life. So that's just one, the OD2A, it's one prevention program that's out there trying to diminish the issue of substance abuse disorder.
Dr. Quinton, thank you so much for joining us. This has been a wonderful conversation. I've learned a lot.
Yes, ma'am. Thank you, Sandy.
I'm Sandy Collier, and we'll see you again next time.
On behalf of our organization, we would like to thank you for taking this opportunity to learn. We would also like to thank our dedicated team and panelists for playing a vital role in making this series possible. Again, if you'd like more information on T. Lee Ward Jefferson Medical Society, please log on to our website at tljmedicalsociety.org. Thank you again. Have a good night.